a vested interest in my healthcare to access my healthcare record. It should be common sense, and I think, you know, if you've got it implemented, and it's a brilliant example of actually in practice, rather than me talking about this hypothetical thing shortly, you know.
Yeah. But in Qatar, we do have the health card numbers for every person here in Qatar. So for us as expats, when we arrive to Qatar, part of the process of boarding, we establish the medical record with this health card. And it's the same for the citizens as well. So the health card, but I'm not sure if the health card number is the same of the ID numbers that we carry as well. It could be two different things. They could be linked in the main data system, but it is pretty advanced. But when you talk about the Middle East, they're not all equal, by the way.
Yeah.
There are healthcare systems that really going through absolute failure and mess, especially because of conflicts and war zones and stuff like that. Complete failure, unfortunately.
Yeah. It should be such a fundamental thing as well, you know. I'm a firm believer in the NHS being from a British background and having worked in it, but free healthcare for all, no questions asked, you know, should be a basic human right, I think, you know.
Yeah, if you advocate that in the United States, they'll say you're a Democrat, you're socialist, and they will shut you down.
Absolutely. Well, I'm not red.
I know, me neither.
Susu, with those questions that you sent me,
yes,
would you like me just to pause it between each section just to sort of facilitate that?
Remember where I put a note
with the slide numbers?
Yeah, with the slide number. So once you reach there, if you give me the chance to
no problem
engage you and the audience with some of these questions and have an open discussion.
I would say though, if there's a timely thing that comes in the chat, feel free to, like, you know.
Yeah, sure, definitely.
Guide us as we go type thing, you know.
Yeah, I will keep an eye on that for sure.
So I'm going to put
I don't have any slides to share, so it will be just me moderating, and all the slides are yours.
Grand.
Yeah.
I'm just going to put mine up now, if that's all right, so that I know that it's visible.
Yeah.
And
sure.
Like, so in theory, hopefully you guys can see that. I can hopefully see that. Where can I pop the chat out from somewhere? Potentially not.
Dr. Susu will have the chat open, so she will be able to relay questions.
I will keep my eye on the chat for sure.
Thank you.
Okay.
And I see a lot of people saying good evening. So good evening, audience.
Good evening, everybody. Okay, so I think we'll make a start for today's session. So thank you, everybody, for joining us. It's good to have you back. We're very excited this evening for a very interesting event, Connected Health for Clinicians, beyond the virtual consultation. And a big thank you to Dr. Rob Argent, who's joined us from the Royal College of Surgeons in Ireland. And a big thank you as well to Dr. Susu Zuhair. As always, she's been very supportive of our CPD activities. She'll be moderating today's session. So thank you before we start. As always, we'll be streaming this event live on YouTube. So we encourage you to post your questions on our YouTube page. And also within the chat, we'll be monitoring that throughout today's session. So please do engage, ask your questions. We find that the interaction really helps to generate more interesting discussion. So please do use the chat function. As we have more attendees joining us, we'll just spend a minute just to talk about some upcoming sessions that we have. So today, as I mentioned, we've got Dr. Rob joining us. The next session will be on Monday, the 14th of February, where we'll have Dr. Ahmed Al-Mullah, and he'll be talking about tobacco control in Qatar. This event is scheduled slightly differently to our normal event. This will be a daytime event between 12 and 1 p.m. where you can register and join the session in the usual way, and all the details can be found on our website. At the same time, we'll be continuing our weekly dental session, and again, you can find all details on the website. In the coming days, we'll be releasing our February newsletter, and that will contain some further updates of activities that the CPD team have been involved in. So I think we've got a good number to start with today. Dr. Susu, I'll now hand the microphone over to yourself. Thank you.
Right. Thank you very much, Dr. Zakaria, and thank you, Dr. Rob Argent, for joining us today. Good evening, everyone. So as you know from the title that we have here, Dr. Rob will take us through a journey discussing the connected health for clinicians beyond the virtual consultation. So what does that mean? You know, with the advancement of the artificial intelligence applications, all the Internet of Things, all the smart applications, as we live currently in the fourth industrial revolution, all these advancements together should benefit human in many aspects, most importantly in human health. When you think of the connectivity of the digital records, for example, starting from the patient digital records, moving to using AI-enabled applications that assist in decision-making, all the smart sensors and all the smart IoTs that are used, whether for telemedicine purposes or for screening and monitoring, etc. When you think of all these things, what would be the benefit? Definitely, it should help in reducing the cost of healthcare delivery, and more importantly, the efficiency and the proper healthcare delivery would be enhanced. So to talk more about this subject and in details, we have the expert with us here. And I want to properly introduce Dr. Rob Argent with us today. So your CV is very impressive, but I'll inform our audience a little bit about you. So Dr. Rob Argent is a registered physiotherapist to start with clinical and research experience in rehabilitation medicine and digital health. At the Royal College of Surgeons in Ireland, he leads modules on both the undergraduate and postgraduate courses of the Future Pharma Beyond the Pill program, which is funded by the Irish Higher Education Authority. He's a qualified physiotherapist, so he spent several years working in the UK's NHS in musculoskeletal rehabilitation, with an interest in improving efficiency and standard of care by utilizing innovative technology-driven methods. He moved to Ireland to undertake his PhD in the University College Dublin, and he was part of the European-wide Connected Health program. His PhD research, which I find very interesting, by the way, was based on the design and development of a wearable technology platform supporting patients in orthopedic rehabilitation. As well as an extensive clinical background, Dr. Argent has experience in innovation and entrepreneurship, machine learning applications, user experience and usability research, and user-centered design. Dr. Rob has since worked at the Insight Center for Data Analytics in University College Dublin on industry-funded research projects concerning digital biomarkers and wearables. Dr. Argent has been member of the European Network for Joint Evaluation of Connected Health Technologies. And in final year of his PhD, he led actually the working team on a proof of concept grant to explore commercial opportunity of the system developed as part of this research. So there's also raking benefits of all these knowledge and education that with research you've done. Dr. Rob is at the Royal College of Surgeons in in Ireland since March 2020, and his primary research interest, again, is in patient-facing digital health applications, often utilizing wearable devices. Without further ado, floor is yours, Dr. Argent. You may start.
Thank you very much, Dr. Suzu, and what a lovely introduction. Thank you so much for having me. I was just saying before we started this that I think this is a really exciting CPD program that you all have together. So I hope we can have some interesting discussions today and learn something along the way. And I hope to learn something from you guys as well. So please feel free to jump in at any time on the chat. And I know Dr. Suzu is monitoring that if you have any queries or anything like that. But without further ado, yeah, I wanted to really talk about connected health, not just maybe what you have come across, and move into where this space might take us in the future of healthcare. So first of all, if I can make sure I've clicked, super. And as Dr. Suzu says, I'm a clinician first and foremost. So I always come at this, hopefully from a very similar angle to many of you, that it's about patient care first, and then the implementation into clinical pathways, rather than coming at it from a slightly more technical perspective. But that also will show some of my biases. So as Dr. Suzu says, I studied physiotherapy as my undergraduate degree, and then I worked in the NHS. And really, all of my time in my clinical kind of philosophy that led me into my academic work is about maximizing the opportunity that we have to gather data and to use it in a meaningful way that improves life for both us as clinicians, but more importantly for our patients as well. And from my experience, there was a huge amount of data in recent years that we're collecting that's completely wasted. And that's largely due to either the method of capture or the processes that are in place for the management of that data post-collection. And so the aims of this session are to be able to articulate what connected health is and what's driving it, to look at some of the challenges associated with delivering this model of care, and then we will have a look at the range of clinical applications that connected health can impact. And then finally, let's have a chat about how to appraise each system, so that what I'm hoping is that some of you may be in a role, maybe now or in the future, where you're looking to promote connected health, and you may be looking to implement connected health into your health service, and you need to know what questions should be asked of digital interventions to ensure that they're implemented and that they're appropriate, and that they're actually offering value to the health system. So before I start, can I ask if anyone's feeling brave enough to type in the chat what they understand connected health to be, or any examples that they might have of what they think connected health is in practice. And that can be really simple to really advanced things. Just want to get a sense of what people are. So super telehealth, exactly that. Maybe live medicine. Yeah, exactly. Telemedicine, brilliant. A conceptual model centered around telehealth. Wonderful. Has something to do with IP, to stay connected with patients at all times. Yes, definitely staying connected with patients at all times and using technologies to monitor diseases. Exactly that. Mobile health, yes. Super. I'm going to try and put a bit of a frame around all of those concepts to lead you into exactly what connected health is, but it incorporates all of those lovely health beyond geographical restrictions. I missed that one. That's exactly it as well. So I think before we go any further, let's have a little look at the terminology, because there are many different terms meaning very similar things, which can differ essentially dependent on your discipline, on your experience, or even perhaps your geographic location. And the lexicon is constantly changing. So as new technologies advance and evolve, and there's maybe new strategic policies, we go from connected health to digital health to e-health, m-health, telehealth. You'd really be excused for thinking that all of these are largely synonymous. And many people treat them as synonymous, but they're ultimately not. And it's really important that we understand some of the differences to that. And I think it's so evident that they're synonymous that I've picked out one Twitter page here, which is eHealth Ireland. And forgive me, some of this is more Irish centric because it's what my kind of go-to is at the moment. And I'm fascinated to learn about what you guys have as in terms of connected health in your ecosystem. But even when we take the Twitter page for eHealth Ireland, the description reports delivering digital health for Ireland, and there's a hashtag for connected health also included. So it's really quite ambiguous, and some of the definitions can muddy the waters a little more. So let's look at eHealth first, and that stands for electronic health, and is a term that traditionally describes the use of ICT in healthcare. And that was used for things mostly like electronic patient records. And the World Health Organization would define eHealth as the cost-effective and secure use of information and communications technologies in support of health and health-related fields, which is really broad. And then when we move to mHealth, it's a little narrower, shortened from mobile health and covering all facets of health provision with the use of mobile phones, tablets, and wireless devices. Okay, then we have telehealth. So telehealth in Latin, tele means at a distance. So with telehealth, we are exactly describing delivering healthcare from a distance. So picking up on that beyond geographical restrictions. And the World Health Organization would define telehealth as also including the use of ICT for the sharing of information. So telehealth, telemedicine, telecare, telerehabilitation, it tends to be used to describe the use of, say, virtual appointments. So whether that's over the phone, video calling, or messaging or the like. And we'll cover this in a little bit more detail because it's the one that most people, including you guys, have kind of thought of when we say connected health. But then we have the Internet of Medical Things. And that is a term that's used in relation to any technology device that utilizes online networking as part of its system. And if we take the example of the video consultation with your GP, and we take those definitions, you could essentially have this virtual consultation through a specialist phone app. Can be eHealth, it can be mHealth, it can be telehealth, and it can be Internet of Medical Things. And it's not just one of them. So then we move on to more recent definitions which use digital health. And that's been used as an umbrella term for all of these other words that we've described here. And that is the combination of eHealth and mHealth, as well as emerging areas such as data science, genomics, and AI. Now, my one issue with this definition is it all talks about technology, and it doesn't talk about the patient in any of this at all. And that is, for me, the fundamental difference on where I see connected healthcare taking us. And if we stay on digital health in the last couple of years, the definitions evolved with the Healthcare Information Management and Systems Society. They start to place the person within the definition. So you can see in this, they're talking of connecting and empowering people, working in an integrated care environment and leveraging digital tools. And I think this is getting much closer to where I would kind of see connected health being defined. And that has been defined as encompassing digital, eHealth, mHealth, telehealth, but also referring to the model of healthcare management. So we place the patient at the center of the process and share data to produce a proactive and smarter approach to healthcare provision. And you'll see with this definition, there's very little mention of technology, but the technology is used to collect the data, to process and create an output. And throughout your career, you'll probably find lots of people use digital and connected health to mean quite similar things. And in this talk, I will probably use both terms, But for me, when I talk about connected health, I'm talking about the model of care, whereas with digital health is more about the tool that facilitates it. And in my opinion, digital health leads us to connected health. Okay. So let's imagine for a minute, what does this look like? Okay. And imagine we manage our health. Oh, where am I? In a fundamentally different way. Okay. Managing health rather than illness, which is what we currently do. So imagine you're 55 years old, you're generally well, and you monitor many facets of your health through your mobile phone app and wearable activity monitor, which all citizens receive from the health service. And you've been tracking lots of metrics. You've been looking at your activity levels, your sleep quality, your diet, your weight, maybe your blood pressure, your heart rate and your mood via this platform. And you can see all your history and trends. And during the pandemic, you got a notification on your app that your weight had increased a little and your activity levels had dropped. And probably like many of us who were stuck at home, unable to do anything and go out and exercise. And you received a little smart notification on your phone. And that motivated you to do a little more, to move and get a little bit more active. And you were issued some educational material on diet and an exercise program. And you got back on track. But recently, you've been having some mild discomfort when out for your daily walks. So you're a bit worried about it. And through the app on your phone, you book a GP appointment. And as well as the standard physical tests, your GP checks your history on your electronic health record, and also some of the recent activity data from your fitness wearable. They also then run a report looking at the heart rate variability and notice some slight changes recently when you've been out for your walks. So your GP then books an appointment with a cardiologist, which you get through the phone app. They also send an electronic prescription to your local pharmacy to collect a more accurate 3-lead ECG monitor that you can wear at home for the week. And that ECG monitor transmits the data via your phone to your electronic health record. And so when you see the cardiologist, they have data from this ECG, and then they can conduct their standard tests, and they notice what might be some mild ischemic change, and they perform their test to confirm this diagnosis. You're then put on a conservative treatment plan, so some diet, medication, cardiac exercise rehab, perhaps with a physio. The pharmacist has all your medications waiting for you, and you receive your personalized treatment plan to your phone with your home exercises and medication reminders to encourage you to be adherent. Your GP is able to see that treatment plan and your response in the data uploaded by the smartphone app. So at no point has anyone had to wait for a chart or a report or for a letter for an appointment. You're, if you wish to, able to access a secure social network with other people with a similar condition. And you can receive reliable and accurate information through the app about your condition, which means you don't have to go and rely on Professor Google, who might not tell you the most reliable information. You respond very well to treatment, and there's no further deterioration in your symptoms. And you're delighted with the care that you've received and how you've responded to it. Now, everything I've just described there, we have to imagine, because for the most part, that model of care isn't possible in our healthcare systems. But we could do all of that right now. We have the types of technology available. We have clinicians in their roles, and that is what is connected healthcare. And Dr. Leroy Hood coined the phrase P4 medicine, which you may have come across in the past, which is widely used to describe the proactive transformation of healthcare, where medicine is preventative, predictive, participatory, and personalized. And in our scenario, we've taken steps to prevent further exacerbation by using data to track symptoms and catch something at its earliest. We've run reports on this data to make predictions of possible ischemic heart disease. We've been involved and participated in the management of our care and our treatment with associated tools to support our behavior. And we've had a treatment plan tailored to our own needs. It's personalized to where we collect our meds, to our level of activity, and based on our own data. But why do we need to explore connected health, and what problem are we trying to solve? I think, any healthcare professional is well aware of current societal challenges, and HIMSS state this in their white paper quite clearly, that global health systems are at a crossroads, facing exponential growth in healthcare costs that are far outpacing the growth rates in the GDP to support health system sustainability. Stretched budgets coupled with an aging population and the rapidly growing prevalence of chronic illness are collectively exerting strain on health systems that are already struggling to cope with demands for services. I thought that was really well put. And I think what we can see is that health policy is responding. And the reimbursement models are being altered with moves towards things like value-based care, where providers are paid based on the outcome of care rather than on the quantity of care that's provided. And this in turn is forcing healthcare providers to look at different methods of providing care and more cost-effective methods of providing care. And these methods can tap into the growing consumerism around health and well-being. And they're really enabled by the ubiquity of technology through our mobile devices and our connectivity. And people want to be more involved in their health, and we only need to look at the explosion of sales in the likes of Fitbits and Garmin's for why there is such an opportunity with health data. And equally, as Dr. Suzu said in the introduction, we're in this fourth industrial revolution, and data is the new oil. And everyone stands to benefit from the harnessing of data as long as it's in the correct manner, and unlocking value for patients and providers, researchers, and also for industry. And then the final big why, and speaking of industry, is from the pharmaceutical sector. And with reductions in new drug discoveries, rising costs of drug development, pharma companies are exploring new methods for unlocking value in care provision. So they might be looking to reduce the demands on resources of drug development. They might be looking to explore decentralized clinical trials, or they may be wanting to have new endpoints within those clinical trials, new digital biomarkers, so that they can prove the effectiveness of one of their current interventions. But there's no doubt that there are plenty of factors driving the connected health space forwards, and there are plenty of benefits to be attained. But there are also obviously a lot of challenges in the way, which we'll come on to shortly. And in order to realize this connected health model, it's important that we consider all of the stakeholders involved in connected healthcare. So if we put the patient at the center, we have caregivers and primary and secondary care and social support services, and even maybe relatives who are informal carers, key to ensuring that a connected health model is successful. And they're working alongside whoever funds the healthcare in the given context. So that might be the public sector, that might be private insurance companies, for example. There are plenty of people to consider and viewpoints to understand. But with connected health, we have an even wider network of stakeholders with technical expertise from data science, biomedical engineering, design and software development, clinical and social sciences working alongside commercial, business and regulatory experts. Connected health requires a truly interdisciplinary approach for it to be successful. And when we look at the process, we can see where this interdisciplinary approach unlocks the value. So the acquisition of health data in a particular context is pivotal to the delivery of the model. So such data may be patient reported. It might be from a sensing device. It could be from standard medical tests. And these data are then aggregated and stored and analyzed, and then they're interpreted in order to provide something useful back to us that we can action a response from in some way or another with an appropriate method. And knowing what to measure and how to make it meaningful requires a very different set of skills to being able to aggregate and analyze these data, which then requires a very different set of skills again to be able to do this in a sustainable and responsible manner. And that is connected health. But how we apply it goes into lots of different ways, and where we are now is a particularly interesting case. But before I move on to that, I just wondered if there are any questions at all from people there.
I'll be monitoring the chat for questions, but I have questions for you, Dr. Rob. What do you think is the level of global readiness for digital health and connected health? When do you expect that it would become the commonplace for healthcare system?
The level of readiness. I think in some ways we're incredibly ready, and in some ways we're a long way away from being ready. And by that I mean, and you probably see from the example, the imaginary piece there is that I think from a technical level, we have readiness. We have the ability to capture these data, to integrate them into health systems. I think where we don't have readiness is more at a policy and a clinical level. That the question is really, will we ever be ready unless something fundamentally shifts in the way we have to, I'll come on to it shortly, but circumstances in the last 2 years have forced us essentially to adopt new strategies. And I think we needed that, because otherwise we could just keep going and nothing changes, and we need that disruption. So where we're at the moment in terms of readiness is we have lots of these little point solutions, and a digital system that will do something, but it doesn't give us connected healthcare.
Yes.
And I think that's probably the best answer I can give to a readiness piece.
Okay, so another question maybe for the audience and for yourself as well. What do you think is the minimal requirements to have digital and connected health, a healthcare delivery system? What are the minimal needs to have this?
I might ask some of our audience first what they think is the minimum that we need for digital health or connected health. What do you all think we need? Good access to technology, a cell phone and a network, yeah. Data security and governance, a doctor, nice, I like that. Still need a doctor.
Yes, of course.
And a pharmacist, and all healthcare professionals, absolutely, and I'll come on to that shortly. Society acceptance, a trained healthcare professional to work with the IT, yeah, absolutely. I am actually going to go a step back from that, because I fundamentally believe, and someone to pay for it, absolutely someone to pay for it. I believe that the minimum requirements is all fundamentally comes back to design. And I think if you design something appropriately, we can negate a lot of these requirements. Now, granted, if you want some remote monitoring in real time, you need to have some infrastructure for connectivity. But I've worked on digital systems that aren't connected, and deliberately designed so because we couldn't be sure that someone had an internet connection. But you can still do a huge amount digitally without needing to have that live connectivity. So I think the minimum requirement depends very much on the use case, and depends very much on how you design a system. A dual way of message conversation and follow-up plus pre-digital session education. Yeah. And these are all things that contribute to digital health systems. But as I say, I think you can negate a lot of them with you can make something, if you take cost, for example, you can make something really, really cheap as a digital health intervention. It may not be the most efficacious, but it could still potentially be better than no intervention. And it's about understanding the use case and the design, which we'll touch on more, I suspect, as we go on.
Right, but do you think if 5G becomes like the common in many countries in the world, would that also help like a leap start for the connectivity of healthcare?
I think it will help. Do I think it's the primary thing that needs to change? No, I don't. I think the primary thing that needs to change is policy and reimbursement policy. And I think the next primary thing that needs to change is that we as a clinical society need to be more willing to embrace and adapt. And I think at the moment we have, and I'll come on to some of the benefits and challenges, we have a real apathy with a certain cohort of our colleagues potentially towards the digital side of things.
Thank you so much. Any question from the audience so far, or should we continue? The very interesting talk, by the way. I think let's continue. Dr. Rob, go ahead.
Okay, super. So now we know what it is. I think you may have all used systems that contribute to connected health. And whilst I'm talking, if you've used any connected health systems, please fire them into the chat. And I suppose what I'm here is that I know I titled the talk Beyond the Virtual Consultation, and I'm going to touch on the virtual consultation, but I'm interested in particular other solutions that you may have used. And if something comes to your mind that you've used, please just drop it in and we'll come back to it. So, but I want to spend a few minutes talking about telehealth, which is something that you've all picked up on in the first part of that talk there. So I think it's probably the most common use of digital technologies that's in clinical practice. And I don't know about you all, but in the last 2 years, I've seen a GP, I've seen a consultant, and I've seen a dietitian virtually since the pandemic started that I never had done before. But there's more to telehealth than this scenario of a patient sitting talking to their healthcare provider. And telehealth can be synchronous, where both individuals are simultaneously present for that immediate exchange of information, or it can be asynchronous, where there's pre-recorded data shared and discussed at different times. And this may take the form of consultations with video, with email, with telephone. It may be sending images. It may be the remote monitoring of certain data, or it could even be something like the triage of referrals. And when we think of telehealth, we typically consider the relationship between the care provider and the patient. But it's also possible to have provider-to-provider telehealth. And this could be in the form of second opinions from tertiary centers. And it could be on reporting on imaging that's taken on the other side of the world, for example. Telehealth is more than just speaking to your GP via Zoom, for example. And here are some of the benefits. And they're essentially the same benefits of telehealth that you can have for connected health. And I think many of them can be linked in one way or another. And if we look at something like reduced travel times, that might be for the clinician as well as for the patient. I had a conversation with one GP who described their choice to take on some extra hours with an online provider. And they chose to be able to work from home. And they were able to do a couple of evenings a week and got paid per consultation above and beyond their normal salary, which offered the clinician extra flexibility and increased her satisfaction in her job. What else we got? Increased patient throughput is interesting. I think, that can mean lots of different things depending on where you come from. It could mean that if you're like me and worked in the National Health Service in the UK, the public service, you can reduce your waiting lists because you're getting more patients through. And that can mean that you've got more efficient staffing and potentially some cost saving. But on the flip side, it could be that you're a private provider and you want to maximize revenue by being able to see more patients in a day. You might have less non-attendances, and then you might have a potentially wider catchment of patients because you're not geographically restricted. I'm going to come back to that question in a moment, if that's all right. There is equally nothing stopping providers using international clinicians, I suppose, to support their patients. So this could be really beneficial in developing nations where there's a lack of specialists, or it might be, I always use an example of Australia because it's such a massive country, that you may have a patient in the middle of Australia who needs a consultation with a unique specialist, and that they have to fly to one of the major urban centres for. And Connected Health and/or Telehealth can really, bring great benefits to that patient. But ultimately, all of these potential benefits can be narrowed down to two hugely important factors. And that is that access to healthcare is better, and there is no discrimination based on your geography, on your socioeconomic status, on your ethnicity, or on your general health. And if we can improve access and equitability, then the holy grail is to improve the quality of care and therefore the outcome of that care. But the list of potential barriers is nearly as extensive. And some of these may be systemic, such as reimbursement or governmental policy issues. And I think that's what I touched on with the readiness there. But many barriers may be more technical in infrastructure that you guys picked up on. And it might take significant resource to set up a telehealth service or a connected health clinical pathway. And it might take a long time and a lot of resource before you start to see those benefits and potential savings. We then have the digital divide and poor usability of systems that impact its uptake. And we have a number of ethical challenges in a sector that probably doesn't have all the skills in cybersecurity and privacy that perhaps the financial services sector or similar might have. And then we have the contextual barriers in ensuring that the systems fit in with our current clinical pathways. And there's a question there about, could telehealth reduce quality of care? And I think there's a risk that it can. And I think a poorly implemented telehealth service can easily reduce quality of care. And if you're replacing a physical examination with a telehealth consultation, that may not be appropriate, and something may be missed because of the lack of a physical examination, which may be negatively impacting care. And so, yes, it could. And the responsibility that we have is ensuring that we triage our patients appropriately to ensure that those that definitely need a physical examination are still given that physical examination, for example. Hopefully that answers that.
There's one more question.
Oh, yeah.
Yes, the question is, do you think this type of health services would be put the patient at the risk of break confidentiality? So the confidentiality of the patient, would it be preserved in this connected healthcare system?
I think it must be, firstly, it has to be. And I think something that is well developed and has met the regulatory processes, and certainly I speak from a European stance, that we obviously have significant amounts of data protection legislation, and I'm sure you have very similar policies in place for that. I think there's that risk, but I think And what we'll come on to just in a second with one of the slides is that what we're seeing is that patients, because of current circumstances, are less cognizant of that and are more, accepting of, well, this is the service. And there's an element of trust, but yes, we absolutely have to make sure that we have confidentiality. But the main providers probably do. Yeah.
There's one more question regarding what happens to patients' data if internet is down and not available for a long time.
Exactly.
That's one of the barriers.
And again, it comes back to responsible design, and any good technology should have built into it, and we'll come on to it when we look at the evidence for digital health systems. Any good technology should have built into it these fail-safe systems. That means that, if we take our smartwatches, for example, they're not always next to our phone. So when it next is connected, it syncs, and we need those options in. But nothing's not possible. Would complete adoption of such telehealth systems risk increasing the gap in access to care? Interesting. In other words, would poor people be? Hold that thought.
Yes.
And we'll come back to that one if that's all right, because I'm going to cover that shortly, especially with regards to AI. So if I don't answer you, Nuran, please chip in again, but I hope to answer that very shortly, if that's okay. But okay. I wanted to talk about COVID for a second, and I know if you guys are anything like us here in Ireland, you'll be bored rigid of this topic, but I wanted to talk about it in something positive to come out of all of this. And the global pandemic has made us change the way that we provide healthcare. And that was to reduce the exposure to our sick patients and to conserve the PPE and to mitigate the effect of huge numbers of patients coming through facilities. So healthcare changed, and they changed the way they triage, the way they assess and cared for patients, and they relied on less in-person services. And so suddenly we had this telehealth system where it was kind of deployed at a huge pace, because we had to be able to provide healthcare in some way, shape, or form. But we had to reduce the risk of transmission to staff and to patients. And so although this technology of telehealth and its usage aren't new, prior to COVID, there wasn't great acceptance beyond, say, the basic telephone communications. And although trends were showing some increase, there was no widespread use. But with COVID, the uptake of these previously kind of underutilized systems was enormous. And so if we take the US, for example, there are reports that nearly half of all Medicare primary care visits in April 2020 were conducted via telehealth. And that compared to less than 1% prior to the pandemic. And I think and I hope that we'll see changes that remain long after all of this is over, and let's pray it's all over soon enough, that we can continue to take these steps towards the bigger connected health picture. And there is some good that's come out of all of this. So how do we move from telehealth to connected health? And I'm going to give you 3 examples of increasing connectedness in a telehealth service. And this first one is a local one here in Ireland. Webdoctor.ie is an online GP service. An asynchronous service starts at €25, fairly basic care. And to put that in context, a GP appointment would be €60 in Ireland. So the €25 is fairly basic, and it seems to require the user know a little bit about what they need in advance. So this might be that they want some home testing for cholesterol or thyroid. They may have a common dermatological complaint, or maybe have something like asthma that they need a repeat script for, or something like that. And then synchronous sessions via video consultation start from €35. But All scripts are still posted to the user. All the GPs are based in Ireland. And I can see in some cases this would be a useful service, but it's quite fragmented, and there's very little integration to a person's healthcare more widely. But it's a step. Then our next step is maybe some of the offerings that health insurance companies are providing at the moment. So for example, I have a policy which gives me free online GP consultations. And then I can get a digital dietitian, digital counseling, digital physio, should I need it. And I describe this as an advancement because it's more connected in a way that, you know, everything's feeding into this one system. So Leia, the health insurer, can probably make savings over me going to my GP and claiming expenses back. And all of this data is stored with them. And then they can refer between the services much easier rather than the siloed GP service that I talked about before. But this is still quite episodic. We spoke about back at the start that only contacts that I have through Leia will be recorded with any medical detail. And so it's still very much a single use case video visit and less connected than we would like it to be. And then finally, we have Teledoc in the US, and I've just realized I didn't share my audio, so I'm going to have to stop sharing and reshare again in a second. But Teledoc is probably one of the market leaders who I would argue have gone beyond telehealth and moved more into connected healthcare and incorporating sort of remote monitoring. And they're essentially an extensive healthcare service that is augmented by digital. And I'm going to play you a video in a sec, but excuse the kind of, it's quite a hype video for want of a better term. It's quite commercial, but I thought it'd be a good way to end this part is to show what the future of telehealth can do. So forgive me for 2 seconds. I'm going to stop sharing and then reshare. Stop sharing and then reshare again. I'm going to make sure I share my audio. And hopefully you've got me back there. If I can get a little thumbs up from someone. Yeah, super. Okay. Okay, so here's a little video.
It was always my vision that we could deliver virtual care for everything. I couldn't really tell people about that vision too broadly. They thought we were completely crazy.
To build this experience that doesn't exist today, it really has caused us to become a company that doesn't exist today.
The Teledoc Health vision is to be the first stop.
That emotional connection to the healthcare ecosystem around you, that's the future. That's the next normal in healthcare.
Healthcare is not a destination that you go to a few times a year. In order to really affect someone's healthcare, you have to be there on their terms in the palm of their hands every minute of every day.
We really have this opportunity to deliver care in new ways to the furthest corners of the world.
We're able to break down all those barriers and bring healthcare to you.
Hey, Simone.
It's clear that we've reached a global inflection point. People are bringing the expectations from their everyday life into healthcare.
We're making it easy, we're making it intuitive, and we're making it truly seamless.
We're doing that today.
We, the tool makers, we now have the technology to make healthcare ambient in our lives. It's always there. It's guiding you to live your healthiest life.
Whole person care starts when people aren't even looking for healthcare and goes all the way to where they're in dire need of healthcare.
Data is the connective tissue between this very disjointed healthcare system that we're coming from. Personalization incorporates the behaviors they're more likely to adopt. The innovations in data and machine learning and AI, working with the human layer, can supercharge and amplify the interaction.
When someone comes onto our platform, we have a full view of everything that's going on with that individual.
We want to power up care providers. We reinforce best practices by training and by measuring constantly.
They're having an interaction with care providers that they trust, who's empathetic, who's delivering the highest standard of clinical quality at every touch point.
We don't
believe
that healthcare should be disrupted. We believe we can transform the healthcare experience by integrating with the healthcare system.
You can wrap virtual care all the way around that system. It's much friendlier. It's much easier to use.
I fundamentally believe that what we're doing is going to change the world.
It's a pretty exciting time to be alive, at least the way I see it.
So we're at a moment in time where somebody has to define the next normal. We're going to be the ones that define that next normal.
Now, there's some big claims in there, and that is not an endorsement or anything of the similar, but the concept is very impressive, isn't it? And I think there's some nice touch points that we can pick up in there to go through in a little bit more detail. And one of the main reasons we can move towards this greater connected health space is here. And the billions of people walking around with smartphones in their pockets. And that smartphone has all sorts of sensors for data acquisition. So whether that's an accelerometer, a microphone, a camera, all of which are connected to the internet in some way. So my phone, for example, has a pulse oximeter. And if you go into the Samsung Health app, you can put your finger against the flash on the camera, and many of you probably have it. Many of you may even realize you don't have it as part of your phone. You put your finger up against the flash for the camera and hold still, and you get an oxygen sats reading. And if you think alone how powerful that could be, there's a wealth of opportunity. And then beyond the smartphone, as I've mentioned, we've all these other devices and so many metrics that can be captured from a really vast sample of people, and that can be used for countless applications, probably too many to be able to name. You know, there's so many opportunities here, excuse me. But the trouble we have at the moment, which is another whole lecture, is that these devices are consumer devices and not medical devices. And consumer products may not always monitor and display the same parameters as traditional medical devices. They may not fulfill their marketing claims, and they might not meet our expectations. And we only have to look into the small print of these companies that offer measures of heart rate and activity, or even maybe oxygen sats, to see their disclaimers, which will essentially say they are not accurate. And the difference between these consumer devices and medical devices is regulation. And ultimately, the way we need to view these devices as they stand, until further development's made, is that if something is medical grade, it is clinically actionable. If it's a consumer device, it may highlight something that we want to explore more with additional tests. So if, for example, my wearable picks up some differences in my heart rate, that is not a diagnosis. That is we might want to look at this in a little bit more detail. Now, I'm going to move on to some applications, but it's probably a good time to pause again if there are questions. I'm afraid I closed my chat when I reshared my screen, so I'm not sure if anything more has come in.
All right. Thank you so much. It's truly very intriguing talk. And I do have a question regarding the cultural variation and cultural considerations in digital health and connectivity. How would that be mended or bridged, or even the acceptability of all these connectivity and digital health among different cultures, religions, ideologies, all this will create skepticism. So how do you envision that would be dealt with?
I think, and I don't mean to keep coming back to design, but as part of design and as part of evidence, these are the two critical aspects we need to focus on here. There is no point in designing a digital health system for the Western market, which encourages behaviors that are not the same in another geographical context. And we have to, you know, a lot of my work is about, we'll come on to the case studies about the user experience and understanding who our user is and who we're targeting this at. Because if we're seeking to change behavior, or if we're seeking to make an intervention, it has to be appropriate to the use case. Right. And so, yeah, you're 100% right, especially some of these consumer devices whose heart rate or their oxygen sats, you know, that has not been validated across a multitude of different ethnicities. You know, it's been, the sample is very much from, you know, likely the Western world in a lot of cases, and that's not right. If we're going to truly unlock the value in connected health. I'll touch on that a little bit more shortly.
Right, thank you. Can we take some questions from the audience?
I've got one here. Older patients are prone to misunderstanding of technology, and they need support or sessions of patient education to get the most. I would agree, but I would also debate that. And I would debate it because I think if older people are not understanding the technology is not designed appropriately for them. And anybody that I've used, and we'll come on to the case that I hope we have time at the end with the case study. I've had a 90-year-old use a smartphone as part of my studies who's never had a phone before and picked it up immediately and knew how to navigate through because it was designed in a way that you couldn't go wrong. And again, it comes back to the use case that older people can if you give them the right platform to be able to do it. And equally, we're all getting older. And so by the time that we truly have connected healthcare, we'll be growing up, we'll be working with people who've grown up with technology, in my opinion. Dr. Suso, I might keep ticking on if that's all right, because I'm conscious of time. I don't want to, yes. I don't want to overrun too long. Is that okay?
Yes, yes.
And if anything else comes in,
we'll open the floor when you're done with your current.
Super. So I want to have a look at some of the examples of where this occurs in practice. And I think, first of all, connected health systems can include relatively simple things. And we've talked about telehealth consultations. But many MRIs and X-rays are now read by machine learning systems, which I'll touch upon in a moment. The provision of electronic health records can contribute to connected health. And any clinicians amongst you will often recall having to spend ages hunting for a patient's chart or a patient telling the same history to a third different person because, you know, there's no electronic health record. We're seeing digital devices being used in the management of long-term conditions. We've got mHealth apps flooding the market, with some being just software and no other, you know, devices involved. And then we have an example of connected health system where companies are using the same technology from consumer wearables, but using it in a more medical context. And many of these example applications use AI. And I thought it would be remiss not to touch on AI during this session. And I want to touch on it in a slightly different way, in a non-technical way. And I want to look at what we mean by two words and their relationships with healthcare. The first one is the intelligence in artificial intelligence. And intelligence is the mental ability of an agent to reason, plan, solve problems, think abstractly, comprehend complex ideas, and learn from experience. This definition doesn't mention the agent's ability to be self-aware, to be conscious, to demonstrate emotional responses, or to have moral reasoning. And Rowe argues in this paper that there's nothing essentially human about intelligence, and that nothing prevents intelligence being represented in computer code. And then when we look at learning, it's the acquisition of knowledge or skills through study, experience, or being taught. And in AI, learning is about maximizing the reward function of an algorithm. And that's very different to how we might understand learning with human beings. And I think it's really important that we don't anthropomorphize these concepts. You know, that can breed confusion and it can breed false expectations. So many definitions of AI that you'll see will talk about how it's the process of enabling machines to think like humans or mimic human behavior. And that's fundamentally, in my mind, not the case. And then we have the attention, or some might say hype, that surrounds AI. And it's been likened to the gold rush, where thousands of people come from far and wide to try and make their fortunes based on unsubstantiated claims, and many come up short. And when we think of AI in health, we have this emerging space where there's huge opportunity with not much value yet realized, and that you can overstate claims of progress and to drive interest or to get funding. And if you go to any digital health conferences, there'll be exhibitors talking about their algorithm doing this or their machine learning model doing that. Yet in many cases, the clinical value of their models is really questionable, to be honest. But here's an example of a really simple machine learning model, because it's important we do understand what happens in some cases. So many radiographs can now be read by AI algorithms. And how this works is that you have a huge data set that's obtained and trained. A model is what's called trained. In this case, let's take this example. There's a huge collection of X-rays of the shoulder complex. And these X-rays have been labeled by a radiologist as having a fracture or not having a fracture. And then with some computational processes that I honestly can't explain, where features of these categories are identified and a model is created. So any new image can be compared against this set, and the model will decide whether there's a fracture or no fracture. And this is a really useful and a really sensible example of AI in health. As you can imagine, it could save huge amounts of time waiting for a radiologist or a physician to report on an X-ray. And the other benefit is that the more data that you have and that's input into the training set, in theory, the more accurate the model can be. And we'll talk about that in the case study, hopefully. So that example is probably the most prevalent use of AI in healthcare in supporting diagnostics. And we've essentially gone from what was initially waiting for a radiologist report. Then when I was working in the NHS, we had our X-rays were sent overseas and reported on overseas and sent back because the labor may have been cheaper. And now it's all automated. And as you can see from the newspaper headlines here, it can be applied across huge amounts of clinical contexts, but it's essentially exactly the same process of machine learning classification that's taking place. Now, one of the most valuable tools in connected health is in early detection, and that can be either for new diagnoses or for exacerbations of long-term conditions. And here I've included 4 examples of early detection systems. We have the Freestyle Libre glucose monitoring setup here. This has had quite good uptake and shows huge benefits, really. Not only do patients not have to repeatedly prick their fingers, so this is a diabetes kit, they don't have to repeatedly prick their fingers with a needle, but their reading can be done with the swipe of their phone across the patch. That reading is automatically recorded and can be visible anywhere, maybe for clinicians or caregivers who might be anxious that their relative has had a hypo, and that data is recorded in history so that you can plot the trend. Then we have the Embrace 2 watch by Empatica and its companion app. And this is a seizure detection device for epilepsy. So if the wearer is having a generalized tonic-clonic seizure, it detects the seizure through its onboard sensors and can notify a caregiver that A, the person is having a seizure, and B, where that person is with GPS, so that that person can get help earlier than previous. And this can potentially offer huge independence to epilepsy patients and reduce their anxiety for them or for their relatives. Then we have the QTUG, which is from a company called Connectedness Health Technologies, and this is more of an in-clinic system, and it conducts a falls risk assessment to identify a person who's more at risk of falls. So that might allow for earlier intervention and meeting that kind of proactive aspect of connected healthcare, rather than, I don't know, waiting for someone to fall before they get put onto a falls rehabilitation program, for example. And finally, we have the Core BPM from Withings, and that's a wireless blood pressure monitor with an integrated ECG, and it has what they call a digital stethoscope. So it's claimed to detect AF and valvular heart disease. And again, the reading is sent straight to the smartphone app and therefore up into the cloud. And then we also have connected health systems which can support clinical decision making. So that might be out there to support clinicians in the selection and the dosage of medications. It might be to use the data to decide on the most suitable intervention, where a surgical approach may be of benefit to one and a more conservative approach may be better for another individual. And equally, many applications in behavior modification. And this is often where the line between health and wellness can blur a little bit. But digital health interventions can be really powerful in behavior change. And the case study, I hope to cover these in a little bit more detail. So I thought I'd show you a fantastic example of how all of this might come together for connected health. We have a method of capturing data. And in this case, this is the ResMed Loomis non-invasive ventilator, which could also then link with another data acquisition device. And we have an infrastructure for supporting remote monitoring and an AI process in identifying those at risk. And then we have a clinical response pathway.
COPD stands for chronic obstructive pulmonary disease, affects approximately 1.2 million patients in the UK. It's the second commonest reason for emergency hospital admission, and the rising number and complexity of COPD admissions is one of the main drivers to rising NHS cost.
Coming into the hospital, a blue light ambulance in at 2 o'clock in the morning because you can't breathe is a horrific and horrible experience, and we're motivated to change that. If we can reorientate care to reduce those patients coming in, that allows us, enables us to deliver better care to the other patients we're seeing.
At the moment, NHS management of COPD exacerbations is reactive. If we're able to predict what may happen with a patient, we can then be much more proactive without having to bring them up and down to hospital. So the data that they provide from their symptom diaries, from their activity monitors, and from the ventilation treatment that they have is collated within an Azure cloud. The algorithms will therefore be able to look proactively in future at patients, so that instead of waiting for a flare-up or waiting for some notification, we're able to see those earlier and change that patient's treatment so that we can avoid a hospital admission.
The number one benefit is a reduction in hospital admissions. Equally as important is that engagement piece of self-management, that ability for the patient to be able to monitor their own symptoms and to proactively manage their condition as well.
We've been able to see a significant reduction in the number of occupied bed days and projected cost saving. If we can upscale this and provide this treatment to 400 patients, that would equate to an NHS cost saving of £1.2 million. And that shows the significant impact on improving patient outcomes.
Because I now know that if there is a problem, the guys here will know about it really before I do almost. It's allowed me to kind of continue with my life really without too much hindrance. I really wasn't able to walk that far previously, and now I can probably do a mile without killing myself. Knowing that somebody's kind of got your back, it's quite a nice feeling.
Using Microsoft Azure Cloud Space provides the best security, and it provides the best prospects for interoperability, the ability to be able to scale the service to apply it to other clinical conditions.
Working with Microsoft Gold partners such as Kensai and Storm have actually been able to just build a really positive collaboration, but they're really motivated to understand our problems and to help us to think about solutions.
I have a chronic condition which is only get worse with time. However, I feel that my care that I've got just now has slowed the progress of the condition down to almost zero at the moment. It's a real benefit to me to be on this treatment and to not have to worry about where my next breath is coming from.
And I think the key thing here is digital transformation. The whole system has adjusted if we're to achieve this change in healthcare and shift to this out of clinic and into the home environment. But understandably, and I'm sure many of you are skeptical of digitization. And we're right to be honest. Technologists disrupt, and they live in this world where you move fast and you break things. And we can't do that in healthcare because breaking things costs lives. And I liken AI to a black box in that you know what is going into the data, what data is going into the model, and you may receive the output, but you've no idea what happens in the middle. And I think where we're at now is we're at this drive to make things more explainable. And, you know, most AI models make predictions, and predictions will tell us that something is true. However, explanations will tell us why something is true. And Watson and colleagues will describe how, whilst we have seen significant developments in this prediction, we've seen a lot less breakthrough in the explanation of outputs. And, you know, in the consumer space, it's kind of accepted that, you know, we might get better search results on our YouTube or Netflix or something, or our Amazon shopping, or we might get a more relevant social network feed because of the AI algorithms that are being employed. And so we don't really care about why we get that. But in healthcare and for patients, it's not clear. And if the algorithm gets it right every time, then this explainability may be less relevant. But we're a long way off the majority of AI systems in healthcare getting right the right 100% accuracy. And then we've got, you know, I touched on it earlier, the GDPR legislation has sparked this discussion over the right to explanation. And they would recommend that an AI system should be expected to provide an explanation in situations where a human would do the same. So such, if a doctor cannot understand why an algorithm has made a decision, then why should patients trust the recommended approach to management? And I think that's really important. And so that might need a whole different shift in the way AI is developed. And there's a lot of fundamental questions that are probably pertinent to talking to developers about that, you know, do we constrain AI to the limit of a clinician's user, you know, competence? Do we restrict it to the level of patient digital literacy? You know, there's a lot of real kind of ethical questions about AI that we're not going to solve today. And then it's not just explainability. Substitution of humans by computers is of increasing concern to many people, not just in healthcare. And, you know, machines are increasingly able to undertake tasks that, you know, are done by humans. And clinicians need to trust that AI is used in an ethical and responsible manner, and developers need to use AI in an ethical and responsible manner. And, you know, there's various statistics around automation, but it's estimated that up to 47% of people in the US are at risk of being displaced by AI-driven technologies. That's not in healthcare, that's across all sectors. But it's more likely that we'll have partial automation, where certain activities and certain occupations might be automated that what I like to do is, and what many of us describe as augmenting the human and the augmented clinician. So we're not replacing, we're augmenting. And we can identify areas where connected health can make a meaningful and safe difference and allow tech to support clinicians to carry out their job. And I think that's the most important thing. But there's a big debate then around the liability of such systems. So who's ultimately responsible in the case where something fails and a negative outcome occurs? And this paper here, Bitterman, Ertz, and Mack, propose a link between autonomy and liability. And so the more autonomous a system is, the more the liability lies with the developers rather than the clinicians. And I think this is probably one of the reasons why most of the AI we've seen in health falls into this red circle here, because it's always an element of clinician input and not fully automated. And that means the majority of the time, the liability is lying at the clinician side of it. I think there's going to be a long way to go before we get to this point where something is fully automated, because suddenly the liability lies on the developer of the model, and that will change things, I suspect. And then finally, for this section, the suggestions that all of this can drive further inequality. And I've seen a few comments in the chat about this as well, and I think it's a really valid conversation. Many of these systems rely on having suitable hardware, internet speeds, infrastructure like you've mentioned, and that can rule out immediately certain demographics from certain countries, certain regions. And I think there's also proportionately less data available on certain minorities. And if we're using data to build models, then those minorities need to be equally represented in those models. I think equally, the nature of these systems is that they're developed by for-profit companies at the moment. And therefore, they're expensive. And therefore, it's predominantly the US and Europe and rich countries that tend to deploy these, but the most value could actually be found in the poorest countries in the world. And we have to make this transition from this profit to actually where we can unlock value. And I think, as I said, even things like SATS monitoring, if you have, if you don't include someone from certain ethnic backgrounds in the training set, if you have skin color then contributing to the method of data capture, how can you be sure that the model is accurate or even generalizable to that population? And that's a really important piece. I'm going to move on quickly into evidence. Dr. Suzu, stop me if we need to. I'm conscious that I can talk for hours on this, so I don't want to.
For the sake of time, if you could finish, please, your last part, and then we will have questions.
No problem. No problem.
Definitely the health disparity and the gap between those who has access and those who don't. It might be actually bridged by the availability of connected health system, but
that's the hope. But it could also exacerbate.
Exactly.
Yeah,
you may proceed, please.
Thank you. So, if we think about assessment of digital health, and I talked about this kind of break things quickly, fail fast mantra. We have this conflict between innovation and between evidence. So connected health research relies on lots of evidence because we're evidence-based practitioners, and that can take a long time and cost a lot of money. Yet that doesn't fit in with the tech companies' kind of mantra. And this is a battle that we're constantly fighting in the digital health space. And there's loads of frameworks out there for evidencing connected health systems. And in this paper alone, they identified, I think it's 45 frameworks were identified, and none of them were able to be used unaltered to guide the assessment of mobile medical applications. So there's like everything else, I suppose, if we get into the real academic side of it, that there's lots of frameworks and you can take bits and pieces from lots of different frameworks that work. There's also aspects that don't necessarily. But what I would just do is I would just draw your attention to the World Health Organization guidelines for monitoring and evaluating digital health interventions, because they talk about the various aspects that should be explored at the various time points across the life cycle of a digital health system. And I think if you're starting out in any research or any kind of questions that you have, it's important to identify what you should explore at which different point. They also talk about the difference between monitoring and evaluation. And for example, if we have an intervention that utilizes text messages as a reminder, in an evaluation, a research team might conclude that the text messages were ineffective because there was no uptake in the intervention. But this might be the wrong conclusion, because you may not have a number of your clients receiving that text message. So in this case, the lack of rigorous monitoring leads to an inability to appropriately state whether something's effective. So the two are kind of working simultaneously, but are separate. That monitoring is an ongoing process, and evaluation is looking at a point in time. And then I'm just going to skip through this one as well. This is the NHS Evidence Services Framework, and what they have is they have a list, and this is one I would explore you to look at if you're involved at all in clinical practice of deploying connected health systems. Is they have 3 different tiers of digital health systems, and then they have essentially come up with a minimum standards and a best practice guidelines for what needs to be evidenced to support deployment of the intervention within the healthcare system. And this covers a huge amount of different topics, from credibility with clinicians, equality considerations, and as you move further along, so the lighter ones are for the higher end behavior change systems that need more evidence. And they have, if we take one example, so acceptability with users, that the minimum requirement for that is to show that representatives were involved in the design and development, and provide data on user satisfaction. And the best practice is to show published and publicly available evidence of the same thing. So that's quite a nice way of saying these are the questions that you need answered to be able to deploy. And I just want to put all this into a context, which is from my PhD work. And this is in an orthopedic setting where if I'm a physio, I work predominantly in outpatients, and typically so knee pain, back pain, etc. And I would routinely see a patient, send them home with some exercises, and they might come back a week or 2 later. And these 3 questions always came to my mind. And as a clinician, no matter what sort of sector, we're somewhat blind to how our patient is managing their condition. And as such, we're potentially not delivering optimal care. And equally, patients feel somewhat blind. And this is particularly evident after surgery, where a patient spends some time in hospital getting high quality intensive care, and then they go home with some crutches and some exercises, and they're kind of left to it here. And it was summed up really nicely with this patient that is quite lonely. You have all the support in there, and then you just hope you're doing it right when you come out. And we know that musculoskeletal care costs a lot, and we know that a lot of patients don't do their exercises after surgery and orthopedic intervention, and we need to be able to support them in doing that. And if you've ever been to a physio, this may look familiar to you. You get a little printout, a piece of paper with some exercises written on it, and this is kind of standard practice. If you're lucky, you might get a stick man drawn on a piece of paper from me in clinical practice, but it's not great. And what we can do is we can use these accelerometers. So this is one of the sensors that I use as part of my work. It's exactly the same as what's in your smartphone that tells you which way up you are, or what's in your Fitbit for your step count. And I look to use it to improve adherence, basically. And if we think about adherence, there's loads of different reasons why people don't do their exercises, whether it's pain, whether it's because they don't believe they can do it, psychological symptoms such as anxiety or depression, and the lack of social support. And then there's also no gold standard for monitoring adherence or measuring it. It's all based around self-report. Oh yeah, I did my exercises. I did. Oh, I took my pills. I took my tablets. Yeah, sure. And we don't have a method of objectively measuring that. And so we have that opportunity to not just measure something objectively, but incorporate features that can change behavior. So we can use coaching and goal setting, self-monitoring, and education to try and improve adherence. And so the system that we had very quickly was we strapped a little sensor to our leg here. And as I did my exercises after my knee replacement, I could first fill in all my pain and my patient-reported outcomes. And as I did my exercises, I got a little animation of a person doing the exercise. It counted how many repetitions I'd done. And then it gave me feedback about whether I'd done my exercise right or whether I'd done it incorrectly. And that was based off machine learning models from the sensor data. And we also included all of the educational material from the hospital, and you can track your progress over time for whether you've done your exercises or not. And we packaged that up in a little system. And I worked with, data science colleagues, software development colleagues, to try and support patients better once they left the hospital. Oh, that's playing again. And if we look at that framework, I was clearly at the prototype level. So I wanted to look at the functionality and the usability and the stability and the feasibility. And so I asked myself various research questions. And so within functionality, we might want to say, okay, well, the functionality is, does the machine learning model provide accurate feedback? And does it meet the needs of the relevant stakeholders? In terms of usability, I also included user experience to understand, what the emotional process is of the patient going through this journey using this technology. So how could we potentially make it better? And then is it actually feasible to do? Now, when we look at data in anything like this is the sensor data that we'd see. So you've got three axes accelerometer data here, and you've got 3 repetitions of an exercise. And the first job we have to do is we have to break each exercise. So I might bend my arm up and down 3 times. I need to first of all take each of those individual repetitions and segment them so I know when each rep starts and ends. And then I can feed it into another machine learning model, which tells me if I've done it right or wrong. And you can see here that there's an asymmetry on this third one with the blue axes that ultimately indicates that exercise wasn't as good as the other 2. And what's really important here is that we evaluate this rigorously. And so what I did is I took the current kind of standard lab cross-validation approach and also then used a brand new set of clinical data from patients with their knee replacement to look at what the difference in accuracy is. Because normally the cross-validation that you see in published papers is probably the very much best case scenario accuracy. It's all kind of collected within the same condition, and your variables are very small. And actually what we found is that once you took this out into the field, that your accuracy dropped significantly. And the results kind of highlighted how, with an independent set of data, after 6 years of research across a number of different groups, and only 4 exercises, this isn't the holy grail. AI doesn't just fix everything. And an accuracy of 60% classification is not good enough for our patients. Despite that, our clinicians, who we did a qualitative examination with, felt it was largely quite positive. They felt that the ability to monitor patients remotely was a good opportunity, and they had some interesting discussions about accessibility of clinical advice to patients, and we had some conversations around automation, for example. But most importantly, we spoke to our patients, and they loved it. And ultimately, what's interesting is that none of our patients questioned the results of the feedback from the system, despite us knowing that it was only 60% accurate. They just assumed that, oh, computers are so clever, I must be doing it wrong. And, that's a really dangerous path that we have to make sure that we are the gatekeepers to making sure that this data is accurate. And as I say, we had one 90-year-old lady who used this device for 3 weeks and didn't want to give it back at the end and didn't have a smartphone. So really, but you have to deploy these systems and assess everyone and everything. And ultimately, what we learned is that the old arguments that older patients can't use technology and it's too complicated aren't really valid when you have a robust design process that factors in the user. And there's clearly a use case here where patients can be better supported with their rehab. And there's clearly potential clinical benefits. But the true value in the research is in the parts that weren't successful. And I would absolutely implore anyone who's looking at machine learning systems to really do their validation and themselves potentially in their clinical context, because that's vitally important. But I want to finish with one final thought before we have questions. And that was the most interesting conversation I've had in my research. And it's around the debate between the art and the science of patient management. And I passionately believe that connected health can unlock huge amounts of value in our healthcare system, but we have to truly understand each use case. And patients getting binary feedback isn't necessarily appropriate because it doesn't take into account how they did a week ago. It doesn't take into account my patient's personality. And if I have Dr. Suzu come into my clinic, she might need an arm around my shoulder, around her shoulder to say, come on, you're doing really well, let's keep doing with this. Whereas I might have Dr. Zach come into my clinic and present exactly the same clinically, but he might need a bit of a kick and he might need to go and crack the whip a little bit and say, you need to do more. And machine learning can't get that human touch just yet. And I think that's a really important thing that we bear in mind, is that we have an art to what we do as healthcare professionals as well as a science. And therefore we need to augment our patients rather than our clinicians rather than replace them. So I hope in that whistle-stop tour of Connected Health that you've got an understanding of what it is. I hope that you understand some of the challenges, and you certainly understood the challenges before. You didn't need me to understand that. And that you see some different applications potentially than you had come across. But yeah, I genuinely believe this is a space to move forward with, and thank you for your time, and I welcome any discussions now or into the future about this topic. So thank you very much, everybody. And I'm sorry I wasn't watching the chat more.
It's fine. If you don't mind to stay with us 5 more minutes.
Yeah. I'm sorry we're over time, but
no, it's fine. Thank you very much. This is very, very intriguing session, I must admit, and it's eye-opener. It's a lot of thoughts that we should consider and think about when we get hyped out about digital and connected health. I do have a question for you. In every healthcare system, patient right is always written and documented as what's the patient's rights. Mm-hmm. Do you think with the future digital and connected health, there should be a universal declaration of patient right that get implemented?
I think it should be universal. I don't know that it should be universal because I think there's not a universal solution with connected health. And therefore, I think that every health system and every health service needs to have this factored into their patients' rights and everything else. But I don't know, by universal, I'm meaning internationally, the patient's rights. Is that what you mean?
Yes, internationally recognized and implemented by as many countries as possible.
I think
recognized as a set of rules as patients' right, like we have the Universal Declaration of Human Rights that we all agree on. I hope there should be in the digital and connected health era, especially with all these very rapid advancement, there should be some form of declaration for patient right.
I think the best I can liken that to is the regulatory aspects of the space. And you know, the FDA, firstly, I'm not a regulatory expert by any stretch of the imagination on medical devices, but the FDA and the EU, for example, will have similar but slightly nuanced things that they have to achieve to be regulated within their, you know, their borders, so to speak. Do I think that that's possible globally? I don't know. I think the use cases can be quite varied. I think first what we need to do is we need to have a better understanding of the regulatory process, because there's certain examples, I think, where, you know, someone will claim something's FDA approved, but it's actually FDA cleared following the 510K process. And then it's because it's similar to something that's already on the market. But that doesn't necessarily the most transparent approach, if you know what I mean. And I'd be very, very keen for transparency, but I don't know that it's possible to have a universal standpoint on it. Yeah.
See, yes, thank you. I'm going to take a couple of questions from the floor. So there's a question from Maria saying, do you think health apps could make people extremely conscious about their health?
Yes, and firstly, I'd argue the positive aspects of that rather than the negative aspects of that. Because like any change, there's not going to be everything hugely positive. If we can make patients more conscious of their health, the hope would be that some of them might take better steps to manage their health within that. Equally, and this was one of the concerns raised by clinicians in my PhD work, was that, well, I don't want you making more work for me because the system's telling them something different. And that is something that has to be worked out, again, in the design and the implementation of a service. And we have to have the sensitivity to know that, you know, I know that if my heart rate on this is saying it's 230 on my smartwatch, it's just wrong, rather than me getting worried. But that's because I have the literacy to understand what this reading means. And I think there is a challenge there, that we can make people more conscious of their health in a potentially counterintuitive way, if that makes sense.
Thank you. We have one more question here. What is the perception of healthcare practitioners regarding connected health? Does it cause increased fatigue?
Can I ask, when you're talking about fatigue, are you talking about fatigue for the clinicians? And just maybe elaborate on that slightly.
I
will keep talking anyway.
Yeah.
Clinicians.
Yes.
I think clinicians are quite welcoming, but I think, are they fatigued by it? I think there will be a cohort of healthcare professionals who may be more fatigued by it because they're less technologically literate themselves. And like any change in any organization, people don't like change. And clinician apathy is well documented with Connected Health. But I kind of feel like it's inevitable that this change has got to happen for the future of healthcare. And therefore, there's an element of this change is, I don't want to say it's inevitable, but it is somewhat inevitable that we have to, as clinicians, be willing to work with it to try and unlock the value. If that answers your question. But yeah, I can imagine some people being like, oh, another computer system to have to use, or oh, I have to log into this now as well. I get that. I see potential fatigue with that.
If is there any more questions or comments from the floor? While they're typing their comments, I would like to express my opinion in this area. I'm actually very intrigued, and I think very positively about the future of digital health and connected health in improving the quality of healthcare. In spite of all the barriers and limitations that have been raised and discussed, yet the potential to having more accessible healthcare with better quality, a cheaper cost is right there. We would like few links to study more such interactive systems. So
I must come clean. The only thing I didn't get to doing was putting a full list of references on my slides, and so I will get that across to you after this with the references that I've used throughout the presentation there. And my apologies.
We post some of that or with the link to them with the recording. Do you like to add a closing sentence, Dr. Argent?
Well, mainly, thank you very much for your time. I think
thank you.
The big thing for me is the more clinicians we can get understanding where we want to take healthcare, the more chance we have of positively influencing those that aren't clinicians who are potentially coming into our space, and that's the tech people and the regulators, because ultimately we understand patient care better than anyone else, and we need to be key stakeholders in that. So the more of you that grasp this concept and want to embrace it, I think your careers will benefit for it. But thank you for being a great audience as well.
Thank you so much. I'll leave the last word to Dr. Zakaria to conclude the session today. It's been a pleasure listening to your talk this evening. Thank you, and thank you, audience.
Yes, thank you, everybody. Thank you, Dr. Susu. Thank you, Dr. Rob. Very interesting topic that we've had today. Dr. Rob, if you could share the references with me, and then
I will indeed. Yeah.
If there are any participants that would like further information, then if you contact the CPD office, we can share those with you via email. I've put in the chat because I think we've had a lot of interesting discussions today, and I think there's a lot more that we could discuss. So please continue to suggest topics for future CPD events, and we look forward to working with Dr. Rob and his colleagues in delivering those sessions for you. Thank you once again to Dr. Susu and Dr. Rob, and we look forward to seeing everybody soon. Thank you very much, and good night.
Thank you all.
Bye, everyone. Good night.
Good night.